Okay, guys, this one's a little bit different because this one's talking about a release of a tendon rather than a repair. And it is technically kind of a repair as well. So the extensor carpi radialis brevis of the elbow. Why they really just do a release on this particular tendon when people have extensor tendon issues, I really don't know, which is probably not very helpful. But this is where the surgeons tend to come in, and you'll see we have all of these different wrist extensors, right? There's wrist extensors, and then there's the finger extensors, and they all kind of clump together and all attach basically on the lateral epicondyle at the elbow. And so that's why we call this lateral epicondylitis when there's irritability. We talked about this when we talked about tendinitis versus tendinosis in the tendon lecture. And you can see here we've got the extensor carpi ulnaris, extensor digiti minimis in there, extensor carpi radialis longus, and then the brevis, and then the extensor digitorum. So we have a lot of these different muscles. For some reason, that brevis tends to be the one that gets the most irritable and the most tight, and so we have to release it. So it basically, if you think of just that one, it's basically going from that lateral epicondyle to the third metacarpal, and it extends and abducts the hand. Okay, those are the two primary things that it does. So you'll see here again, this is a picture of that lateral elbow, the lateral epicondyle, and how it could get irritable. So we talked about how you have the difference between a tendinitis and a tendinosis. You can see on the right-hand side, it kind of shows a picture of a healthy lateral epicondyle. And remember, those are the nice straight lines of the tendon where that collagen is laid down nice and straight. And what happens with a tendinosis is that we tend to get those microscopic tears. And then as it tries to fix itself, then we end up with that kind of weaving pattern that's not as healthy, it's not as efficient in muscle contraction. So this is just showing you a picture where there's a little bit of a tear that's in this case, this is the ligament, but you'll see that there's just a lot of irritability and change in the soft tissue when patients are complaining of lateral epicondylitis, or then the other name for this is tennis elbow. So when we talk about this, another way we can think of tennis elbow is they're starting to use these other terms called reactive and degenerative tendinopathy. So reactive tendinopathy is very similar to a tendinitis. So reactive tendinopathy is defined as a response, so the tendon gets irritable because of some sort of unaccustomed or increase in activity. And so you recognize that you have to decrease the load. You have to kind of then change the activity ultimately for recovery. But again, this is going to be one of those things where either you've never played tennis before and you take it up and it's just the elbow gets really, really irritable because it's the first time you've ever used a tennis racket. Or, the example I gave with the tendon lecture, you're somebody who decided to paint a ceiling or something over the weekend, and so you have that irritability. So another way that that's talked about in the literature is reactive tendinopathy. Degenerative tendinopathy is what we talked about as a tendinopathy. So this is where there's degeneration to the tissue. This could also include nerve irritability. So the radial nerve passes through that area. Any of you who have taken my class of the upper extremity, we talk about where you can palpate the nerve to figure out if the nerve's involved, to see if it's nerve and tendon or if it's just nerve or just tendon. But oftentimes there is some irritability of both. And then this is the one where you actually have changes in the structure of the tendon. And so that collagen production, again, makes those kind of crosshatch looking tendon, which can cause decreased power and decreased issues. So this is one where with degenerative, we're going to be using a lot of eccentric exercises, which we're going to talk about as we go through this. So you usually are going to have that micro trauma, and the micro trauma, again, I guess it tends to happen the most to the extensor carpi radialis brevis. And so when you see on imaging this lack of the nice pattern of collagen laying down, you're going to see that irregular structure. You may see thickening of the tendon. There may be calcification within the tendon, as well as increased blood flow. So again, they're trying to the body is trying to go in and try to heal something that's broken, heal a tear. So other structures can be involved. When we talk about this, the primary structure that surgeons tend to go in and try to release or fix is that extensor carpi radialis brevis. But if you look at the anatomy here, there's going to be other things there, that things like even the annular ligament. So around the annulus, around the radial head could be affected. Collateral ligaments. So again, the lateral aspect of the elbow, any of those ligaments could be affected. The capsule could be affected, and then the big one that we have to really be careful of is the radial nerve. So making sure that the radial nerve is not affected. But sometimes they may have to go in and do some things, maybe move the nerve a little bit to decrease irritability. So a lot of people get lateral epicondylitis, right? A lot of people get that tendinopathy. The rate is 1 to 3% of all people. So it's possible that people get this kind of regularly. It usually happens people 35 to 50 years old, and 30 to 50% of the time it's tennis players. So that's why we call it tennis elbow. It's a very common problem with tennis players. I don't know how much research is done. I know you guys do a lot of badminton and table tennis. I'm guessing that there's some pretty good research out there that it's just as likely, or in China there's even maybe a higher percentage of patients presenting with this problem who are playing badminton or table tennis. How do we diagnose it? Diagnosis is palpation is a big one. So you're palpating, is there significant tenderness as you follow the extensor carpi radialis brevis, not the muscle itself, but the tendon. Pain with resisted extension, supination, and gripping. Okay, so we know that with any type of lateral epicondylitis, we're testing extension, we're testing supination, but also grip in this case can be affected. MRI, ultrasound, obviously those things can help us see if there's significant thickening of the tendon, if there's micro tears, those kinds of things. So for non-operative treatment, so again, this is our lateral epicondylitis basically. You can do modalities to decrease irritability. Exercises, you're going to start off with isometrics, okay? So we talked about how with these different things, you kind of have to follow irritability level. You really, with these patients, there's going to be pretty high irritability usually if they're doing a lot of resistive exercises. So you're starting off with pain-free isometric exercises, and you're holding it for like 30 to 60 seconds. So you're not just doing 30 to 60 seconds daily. I think that's probably written a little funny. But you're holding 30 to 60 seconds as an isometric into wrist extension, and you're doing this with the wrist in different positions. So you're starting at like 0 degrees and then 20 to 30 degrees of extension. And then watch the position of the elbow. If the elbow's in too much extension, it's going to be much more irritable. So you want to start off with them in 90 degrees of flexion at the elbow, and they're going to have a lot less irritability. You're then progressing these isometrics to like 90-second hold, and then you can start adding some free weights and some other resistance. As you're doing this, make sure that the wrist stays in neutral. I think we've talked about this a couple times before, especially women love to do like crazy supination, pronation. I'm sorry, not supination, pronation, but like radial ulnar deviation positions with the wrist. So you really want to make sure that if you're basically looking at like the wrist, that the lunate and the third finger are lined up directly. Like there's a straight line between the wrist and the third finger. They're not going into radial ulnar deviation. as they're doing that wrist extension. So again, that just helps to decrease irritability. For degenerative tendinopathy, so the last one was for that reactive tendinopathy, so that tendinitis, that acute version. For degenerative tendinopathy, you're going to start off maybe with some bracing. You can consider bracing. There isn't great research to show that bracing is really helpful, but if the patient already has a brace, or if you want to do something like taping with them, it can be good. I think exercise, there's a lot more research related to exercise. So for manual therapy, you can do Dong Tai Song Dong, MWMs. You can also do some soft tissue work. If there's nerve irritability, you may consider treating the cervical spine or the thoracic outlet, and possibly do nerve mobilizations if the radial nerve is involved. Again, for this degenerative group, you're going to be really focusing on eccentric exercises, okay? So there's a good amount of research about how awesome eccentric exercises are for this patient population, even more so than concentric. So again, we've done some of these examples of these exercises in my upper extremity class. You really it's better, I think, to literally manually pick up the hand and put them into wrist extension, and they can do this themselves with their other hand. Put them into wrist extension and then slowly lower down. You're doing this over the table with either a weight or elastic band, and then you're going very slowly. So you're kind of going er sun tsu, and then releasing it, and then bringing it back up into that extension position, dropping it down, er sun tsu. 2 to 3 sets of 10. And then remember, we're starting at that 90 degrees of elbow flexion. And as you progress, they can start increasing elbow extension and they can start increasing weight. So all of those things will help. So we've kind of talked in previous, in some of the other lectures that I did about, pain tolerance. Some research would say they should be the resistance that you give, they shouldn't have any pain. But I would say as long as the pain is less than a 3 or about a 3, you're probably fine. So don't stop if they're saying, oh my gosh, I have pain, if you're using, like a half a kilo or a water bottle or something. I would seriously say as long as the pain's not significant, it's fine. You really want to try to start these eccentric exercises early and follow this kind of prescription for eccentric exercise. The other really important thing is scapular exercises. And this is true partially because, again, if there's nerve involvement, you really want to make sure that the scapula position is good to decrease irritability of the nerve, right? So we know that scapula position can help with posture, can help take irritability off the thoracic outlet. So any type of closure of the thoracic outlet can lead to irritability of the nerve, radial nerve, possibly. The other big reason that we want to do scapular muscle exercises, strengthening, is because those movement patterns that are needed for tennis use a lot of scapula control. So if they're not using their shoulder and scapula correctly, they're overusing their elbow. So we've seen this a million times. Those of you who work with tennis players, you probably know, you have to spend a lot of time on the scapula. So with this group, post-op or non-operative, you really want to make sure that you're assessing all those good scapular muscles and that you're providing treatment for the scapular muscles as well as these eccentric exercises for wrist extension. All right, so about 21% of patients are going to require some sort of surgery. They don't suggest doing steroid injections. And you guys don't see a lot of cortisone injections here in China, so that's good. They're used very frequently in other parts of the world, and they really say that, again, especially if the patients have comorbidities like diabetes or something, you really should not be doing cortisone injections because it does really weaken the tendon, and they're more likely to have tears, like a full tear, which is a problem. So if they've had cortisone injections and it's not been helpful, then they're probably going to do surgery. Or if they've tried conservative care for like 12 months and it's not improving, then they're definitely going to consider surgery. So they're going in percutaneous cutting of at the lateral epicondyle, and then they're releasing that extensor carpi radialis brevis from the anterior aspect of the radial head, and they're debriding around it because, again, there can be some bone spurs, some calcification, so they're trying to get rid of any of that kind of stuff. They may be doing that around the extensor carpi radialis longus and other muscles as well. So again, all these tendons come together at the lateral epicondyle. The thing is, again, this surgery doesn't have, when they compare doing surgery and not doing surgery, there aren't amazing differences in the outcomes. Sometimes if they do a release, you may have more complications. There are research that says, if one group does a release, one group just does debridement, there's no significant differences in outcomes just to do debridement. So they may just want to go in and do that. But again, that's obviously up to the surgeon. So you might see different things. What's nice about doing debridement without a release is that you can do rehab a little bit faster. Usually maybe 1 or 2 weeks you can progress a little faster if they're just doing debridement, because again, the tendon is still intact. So yeah, there's all different things they could do for that surgery. So make sure you're looking at the op notes, seeing if they had to go in and obviously debride multiple tendons, or if they had to release different portions, then you might have to go a little bit slower. So luckily, there aren't huge amounts of complications. 83 to 89% have no complications. If they do, it's possible that they would get stiffness. So this is the big complication we always see at the elbow, that heterotropic ossification or just significant stiffness because the patient was immobilized for too long. So that could be a problem, and then they have to go in and do a surgery where they, manipulate it. They could lose power to their extensor tendons, so they may come out with less power compared to the other side, or less power than they had obviously before the surgery, which we know is possible. Nerve injury, we definitely don't want nerve injury, but it's so close to that radial nerve that it could happen. Infections, and then different kinds of infections. So preoperatively, you're kind of just giving them all the good post-op information. They are going to be staying in an immobilizer for a period of time after the surgery, so they need to be aware of that. Kind of showing them how to sleep is always helpful, and making sure they know that even though they're having a surgery on their elbow, it's going to affect their hand, but their shoulder, they need to be moving their shoulder as much as possible. First phase, usually 3 weeks, and it's basically protected motion phase, but we do practice range of motion. So we do want 80% of normal range of motion at the elbow by the end of that 3 weeks if we can get it. So you can see that this one, they're not being immobilized for several weeks like some of the other ones are. We are allowing for some range of motion during this first phase. So they do need to wear a sling. So there is immobilization, but we're allowing for passive range of motion. And we're also allowing for some hand movement, which we'll talk about in just a second. We do obviously want to watch for pain control and infection. And the sling, it depends. If it's an open repair, it's going to be longer than if it's an arthroscopic repair. And again, it depends on how much they did for a release versus maybe just debridement. But they are going to wear a sling for a period of time. Oh, here we go. So sling is really, they're going to wear 2 to 4 days if it's arthroscopic, but maybe up to 2 weeks if it's open surgery. They obviously can take off the sling because they're going to be able to use, by day 7, they can use that arm for light activity. So they can move it around, okay? So there isn't any reason why we can't do some active range of motion. And then if you're seeing them during the first phase, during those first couple of weeks, you can do passive range of motion, no problem. Like just go for it. Passive range of motion at the elbow. You definitely want to move fingers and wrist starting at day 3. So active range of motion, just gentle active range of motion. Remember, there's a lot of other muscles that are doing the job of wrist extension. So especially if they're just releasing one muscle, you should be fine with doing active range of motion using the other muscles. We're not repairing anything, so there isn't anything that needs to be, we don't need to be as conservative with these guys because we're releasing muscle and debriding. We're not repairing anything that we need to be conservative with. So the second phase is from week 3 to week 6. So we really are looking for decreased pain at this point. So the first couple weeks, there may be some pain, normal after surgery, but by week 3 to week 6, they really should be back to better than they were before surgery. We also really should have full range of motion. So again, these people, we should be pushing a little bit harder and a little bit faster than the people who need some sort of repair, right? Actually, a lot harder and faster than people who need a repair. So we should really, by 6 weeks, have full range of motion. So that's going to be elbow range of motion. That's going to be wrist-hand range of motion. So during the second phase, I would say if they're working at the computer, then you have to wait at least 4 weeks. But if they're not using a computer, they can go back to work to do things like picking up the phone and things like that at about 2 to 4 weeks. If they are going to start doing some exercise, they definitely want to use some ice if they're going to do that. And then if they're finding that they're trying to do we're going to talk about resistive exercises. If they're doing resistive exercises and they're having pain, and they can use one of those, they're called counterforce braces. It's also called a CHOPAT strap, CHOPAT strap. Or you can just look up, tennis elbow brace, and you'll find it. So they can do that during the second phase when they're starting to do resistive exercises again. Okay, so we can start doing anti-gravity movements as long as there isn't significant pain. And again, I'm going to go with that. If it's 3 out of 10 or less, you're okay. And then once they can do 30 reps without pain, so that's how you're gonna decide, okay, they're fine now, they've got 30 reps, then you can move on and add some weight. So you're doing this without resistance, and then you're adding the weight. And when you add the weight, again, 3 out of 10 pain should be fine. Progress from that flexed elbow. So just like we talked about with the non-operative treatment, you're progressing from that fixed elbow flexion at 90 to elbow extension. You can do some light stretching at this point with light overpressure, just like we talked about with other elbow things. That anterior aspect has so much fascia on the elbow that tends to get very tight. So if you need to do a little bit of gentle stretching into extension or into flexion, that's fine. You obviously want to continue doing aerobic exercises, which, is kind of assumed, especially for your athletes. I think most of them are going to be doing that. And then you want to do, the other treatment is going to be a little bit of just kind of soft tissue work against the fiber orientation. So a little bit of like cross friction, gentle cross friction of the extensor tendon. Phase 3 is going to be from weeks 8 to 12. So at this phase, we should be really getting back to things. I know it doesn't say return to sport, but we're already starting to do resistive exercises in phase 2. So by phase 3, we're really focused on resistive exercises. And that includes grip. And we talked about grip a little bit before. It's really important that you use something to measure grip. You'll see there's a dynamometer there in the picture for measuring grip. I think that's your best bet because it's hard to measure grip otherwise. So it's worth it to have one of those. I think they're kind of expensive, but not too bad. And so you want their grip to be normal, what's considered normal. Usually this is going to happen on their dominant side. So that dominant side should technically be stronger than your non-dominant side. But regardless, you want to make sure that they're essentially at least equal to the other side. Unless it's the non-dominant side. I guess it could be a little bit weaker. But we want them to be able to do that grip strength without pain. And this is kind of where we can start saying, okay, you can start really returning to sport, like 100% return to sport. Keep using a brace if you need to. So this is where we're really doing a lot more functional activities that are task specific. Again, most of the people that are going to have this surgery are athletes. So, we don't call this the sport specific training phase, but it really is. Like by phase 3 with this group, you should be doing some sport specific activities and starting to get back to return to sport. So, you'll see examples, pictures of different things here. We sort of talked about eccentric exercises. Yes, eccentric exercises are definitely part of even phase 2 into phase 3. And then you'll see these are a lot more dynamic activities. These are much more related to sports activities that are plyometric and dynamic. And then you're really focusing on those things, but also continuing with strengthening. So we were doing strengthening already back in phase 2, and now we're increasing our strengthening. So last phase is sport-specific training, and this is going to start, this is basically return to sport. So in phase 3, you're already doing a lot of sport-specific training, but you should be able to go back to return to sport. So it's suggested, however, that if the patient is somebody who's doing heavy lifting, especially repetitive heavy lifting, that they shouldn't start doing that stuff until 12 weeks. So again, starting to return to sport and doing sport activities before 12 weeks is fine. But if there's somebody who's doing a lot of lifting and a lot of repetitive movements that use the wrist extension, they should not start that until 12 weeks. So here's a little video giving you some suggestions on some really good strengthening and kind of sport-specific exercises.